Question 1. A 45-year-old male presents after a high-speed motor vehicle crash. He is hypotensive, BP 70/40 mmHg, tachycardic, HR 130 BPM, and his left thigh is grossly deformed with external rotation. He has received 2 liters of crystalloid en route with no improvement in vital signs. The most appropriate next immediate step in his management, after ensuring a patent airway and adequate breathing, is to A. Perform a focused assessment with sonography for trauma, FAST, exam. B. Initiate a massive transfusion protocol, including early administration of tranexamic acid, TXA. C. Apply a traction splint to the left thigh and reassess vital signs. D. Insert a central venous catheter for definitive fluid resuscitation and vasopressor administration. Answer: B. Initiate a massive transfusion protocol, including early administration of tranexamic acid, TXA. This question tests the understanding of hemorrhagic shock management, particularly the 2025 ATLS emphasis on early blood products. The keywords high-speed MVC, hypotensive, tachycardic, and no improvement after 2 liters of crystalloid strongly suggest ongoing severe hemorrhage, likely from the deformed thigh and potentially internal sources. Initiating a massive transfusion protocol with early TXA addresses the core problem of severe bleeding and coagulopathy, aligning with current ATLS guidelines that prioritize blood products over crystalloids for persistent shock. For instance, in severe trauma with ongoing bleeding, giving blood quickly is more effective than just giving more saline, and TXA helps stabilize clots. Remember, persistent hypotension after initial crystalloid points to the need for blood. Question 2. A 3-year-old child is brought to the emergency department after a fall from a second-story window. Initial assessment reveals a GCS of 8, absent breath sounds on the right, and tracheal deviation to the left. Peripheral pulses are weak, and the skin is cool and mottled. What is the most immediate life-saving intervention indicated? A. Endotracheal intubation. B. Needle thoracostomy on the right side. C. Bilateral chest tube insertion. D. Rapid sequence intubation with cricoid pressure. Answer: B. Needle thoracostomy on the right side. This question evaluates the immediate recognition and management of a tension pneumothorax in a pediatric patient. The keywords GCS8, absent breath sounds on the right, tracheal deviation to the left, weak pulses, and cool/mottled skin are classic signs of a tension pneumothorax causing obstructive shock. While the child also requires airway management due to a low GCS, the tension pneumothorax is an immediate, life-threatening cause of circulatory collapse that must be decompressed first. Decompressing the chest, for example with a needle in the second intercostal space, allows the heart to fill properly and restores circulation. Always address the most immediate life threat causing circulatory collapse first in trauma. Question 3. A 72-year-old male on warfarin presents after a fall, sustaining a head injury. His GCS is 15. A CT scan of the head shows a small subdural hematoma without midline shift. His INR is 3.5. Which of the following is the most appropriate initial management strategy regarding his anticoagulation? A. Administer vitamin K orally and repeat INR in 24 hours. B. Administer fresh frozen plasma, FFP, and vitamin K intravenously. C. Discontinue warfarin and observe closely for neurological changes. D. Administer prothrombin complex concentrate, PC, and vitamin K intravenously. Answer: D. Administer prothrombin complex concentrate, PC, and vitamin K intravenously. This question assesses the urgent reversal of anticoagulation in an elderly trauma patient with an intracranial hemorrhage. The keywords 72-year-old, on warfarin, head injury, small subdural hematoma, and 3 Indian rupees, 5 highlight the need for rapid reversal due to the bleeding risk, even if the hematoma is currently small. PCC works much faster than FFP or oral vitamin K alone to normalize the INR and reduce bleeding, making it the preferred option in critical situations like intracranial hemorrhage. For example, if a patient with an elevated INR is bleeding into their brain, giving PCC can quickly help the blood clot and prevent the bleeding from getting worse. Prioritize immediate and effective anticoagulation reversal in head-injured patients on warfarin. Question 4. A 28-year-old pregnant patient, 30 weeks gestation, is involved in a low-speed motor vehicle crash. She complains of mild abdominal pain. Fetal heart tones are reassuring. Initial fast exam is negative. What is the most appropriate next step in her management? A. Discharge home with instructions to return if symptoms worsen. B. Obtain a CT scan of the abdomen and pelvis with intravenous contrast. C. Perform a diagnostic peritoneal lavage, DPL. D. Observe in the emergency department for at least 4 to 6 hours with continuous fetal monitoring. Answer, D. Observe in the emergency department for at least 4 to 6 hours with continuous fetal monitoring. This question tests the understanding of trauma management in pregnancy, specifically the risk of placental abruption. Even with a low-speed MVC, mild abdominal pain, and a negative FAST, placental abruption can present subtly and develop later due to the shearing forces of trauma. Therefore, prolonged observation with continuous fetal monitoring for at least 4 to 6 hours, and sometimes longer, depending on local protocols, is crucial to detect delayed signs of abruption or fetal distress. For instance, a mother might feel fine initially, but the placenta could start to separate hours later, so monitoring ensures the baby is safe. Always be vigilant for delayed complications like placental abruption in pregnant trauma patients. Question 5. A 55-year-old male with a history of COPD presents with severe blunt chest trauma after falling from a ladder. He is intubated and mechanically ventilated due to respiratory distress. During positive pressure ventilation, his blood pressure drops significantly, and peak airway pressures rise. Breath sounds are markedly diminished on the right. What is the most appropriate initial intervention? A. Administer a rapid fluid bolus. B. Increase the PEEP on the ventilator. C. Perform immediate needle decompression on the right chest. D. Obtain an urgent portable chest X-ray. Answer, C. Perform immediate needle decompression on the right chest. This question targets the recognition and urgent management of a tension pneumothorax in an intubated patient. The keywords blunt chest trauma, intubated and mechanically ventilated, blood pressure drops significantly, peak airway pressures rise, and breath sounds diminished on the right are classic indicators of a tension pneumothorax exacerbated by positive pressure ventilation. While fluid, A, and X-ray, D, might be considered, needle decompression is the immediate life-saving intervention needed to relieve pressure and restore circulation. For example, if you see these signs, you should immediately decompress the chest because the ventilator is making the problem worse by pushing more air into the trapped space. When a mechanically ventilated patient deteriorates acutely with these signs, always suspect and treat a tension pneumothorax first. Question 6. A patient presents with a GCS of 6 after sustaining a severe head injury. Airway assessment reveals significant facial trauma and active bleeding, making orotracheal intubation difficult. Attempts at direct laryngoscopy are unsuccessful. What is the most appropriate next step for definitive airway management? A. Attempt nasotracheal intubation. B. Perform a rapid sequence intubation with videolaryngoscopy. C. Perform a surgical cricothyroidotomy. D. Insert a laryngeal mask airway, LMA, as a temporary measure. Answer, C. Perform a surgical cricothyroidotomy. This question addresses the critical decision-making for a difficult airway in severe trauma, specifically when traditional intubation is not feasible. The keywords GCS of 6, severe head injury, significant facial trauma, active bleeding, and unsuccessful attempts at direct laryngoscopy indicate a failed airway attempt in a patient who absolutely needs a definitive airway. In this emergent can't intubate, can't ventilate scenario, a surgical cricothyroidotomy is the recommended definitive airway in ATLS, as it is faster and more reliable than other options in this context. For instance, if the face is too damaged to see the vocal cords, cutting directly into the cricothyroid membrane is the fastest way to secure an airway. When oral intubation fails due to severe facial trauma or bleeding, move directly to a surgical airway. Question 7. A 24-year-old unrestrained driver is ejected from his vehicle. He presents with severe, localized pain in the right lower quadrant, an unstable pelvic ring on examination, and a significant blood transfusion requirement after initial fluid resuscitation. After pelvic binding, a fast exam is negative. What is the most likely source of his ongoing hemorrhage? A. Solid organ injury, e.g., liver or spleen. B. Mesenteric injury with active bleeding. C. Retroperitoneal venous bleeding from pelvic fracture. D. Major arterial bleeding from the pelvic fracture. Answer, C. Retroperitoneal venous bleeding from pelvic fracture. This question targets the most common source of life-threatening hemorrhage from an unstable pelvic fracture. The keywords unrestrained driver ejected, unstable pelvic ring, significant blood transfusion requirement, and negative fast exam strongly suggest ongoing retroperitoneal bleeding. While arterial bleeding can occur, the majority of severe hemorrhage from pelvic fractures is venous, often exacerbated by the large retroperitoneal space's capacity to hold significant blood volumes without immediate tamponade. For example, the many small veins in the pelvis can bleed extensively when the bone breaks, leading to massive blood loss even if the fast scan of the abdomen is clear. Remember that even with a negative fast, an unstable pelvic fracture is a critical source of retroperitoneal hemorrhage, often venous in origin. Question 8. A patient with a GCS of 14 after a fall develops unilateral pupil dilation and becomes progressively somnolent, with a GCS now 10. Vital signs show increasing blood pressure, 180/100 mmHg, decreasing heart rate, 50 bpm, and irregular respirations. What is the most appropriate initial medical management while awaiting definitive neurosurgical intervention? A. Administer a large bolus of intravenous fluids to improve cerebral perfusion. B. Administer mannitol or hypertonic saline and hyperventilate the patient. C. Prepare for immediate endotracheal intubation and mechanical ventilation. D. Administer a benzodiazepine to reduce anxiety and agitation. Answer, B. Administer mannitol or hypertonic saline and hyperventilate the patient. This question assesses the recognition and emergent medical management of signs of impending cerebral herniation. The keywords GCS-14 progressing to 10, unilateral pupil dilation, and the presence of Cushing's triad, increasing BP, decreasing HR, irregular respirations, are classic signs of rising intracranial pressure, ICP, leading to herniation. While intubation, C, will eventually be necessary for airway protection, the most immediate medical intervention to reduce ICP and potentially avert herniation is administering osmotic therapy like mannitol or hypertonic saline, combined with controlled hyperventilation if herniation is suspected. For instance, giving mannitol or hypertonic saline helps draw fluid out of the brain, shrinking it and reducing pressure, while controlled hyperventilation reduces cerebral blood flow. When faced with signs of herniation, immediately use osmotic agents and consider hyperventilation to buy time. Question 9. A patient is found unresponsive after prolonged exposure to cold weather. Core body temperature is 28 degrees Celsius, 82 for degree F. Cardiac monitor shows ventricular fibrillation. What is the most appropriate initial action? A. Immediate defibrillation. B. Begin active external rewarming. C. Start cardiopulmonary resuscitation, CPR, and consider one defibrillation attempt. D. Administer intravenous warmed crystalloid fluid bolus. Answer: C. Start cardiopulmonary resuscitation, CPR, and consider one defibrillation attempt. This question tests the management of severe hypothermia with cardiac arrest. The keywords unresponsive, prolonged exposure to cold, core body temperature 28 degrees Celsius, and ventricular fibrillation are critical. While immediate defibrillation is typically the first step for VF, in severe hypothermia, the heart is often refractory to electrical therapy until warmed. Current ATLS guidelines recommend starting CPR and performing one defibrillation attempt, but then prioritizing active internal rewarming. For example, aggressively rewarming the patient, often through internal methods, is key because the heart is too cold to respond well to shocks until it warms up. Remember that in severe hypothermia with VF, rewarming is paramount, and aggressive defibrillation attempts are often futile until the core temperature rises. Question 10. A 60-year-old male with a history of liver cirrhosis presents after a fall from standing height. He is agitated, hypotensive, 90/60 mmHg, and has generalized abdominal tenderness. His GCS is 13. What is the most appropriate initial imaging study to evaluate his abdominal pain? A. Computed tomography, CT, scan of the abdomen and pelvis with contrast. B. Focused assessment with sonography for trauma, FAST, exam. C. Diagnostic peritoneal lavage, DPL. D. Upright chest X-ray and supine abdominal X-ray. Answer: B. Focused assessment with sonography for trauma, FAST, exam. This question addresses the initial evaluation of blunt abdominal trauma, especially in a patient with risk factors for bleeding. The keywords liver cirrhosis, fall from standing height, agitated, hypotensive, and generalized abdominal tenderness indicate a high suspicion for intra-abdominal hemorrhage. A FAST exam is the most rapid and non-invasive initial screening tool for free fluid, likely blood E, in the abdomen, which is critical in an unstable patient like this. For instance, a FAST scan can quickly tell you if there's blood around the liver, spleen, or heart, which is crucial for deciding if emergency surgery is needed. In an unstable trauma patient with suspected abdominal injury, a FAST exam is the quickest way to check for internal bleeding. Question 11. A 35-year-old male sustains a stab wound to the left anterior chest, 3 cm lateral to the sternum at the 4th intercostal space. He is hypotensive, 80/50 mmHg, tachycardic, 120 bpm, and has muffled heart sounds with jugular venous distension, JVD. Breath sounds are equal bilaterally. What is the most likely diagnosis? A. Tension pneumothorax. B. Massive hemothorax. C. Pericardial tamponade. D. Open Pericardial tamponade. This question tests the classic presentation of pericardial tamponade. The keywords stab wound to the left anterior chest in the fourth intercostal space, which is near the heart, combined with hypotension, tachycardia, muffled heart sounds, and JVD, Beck's triad, are pathognomonic for pericardial tamponade. The absence of diminished breath sounds rules out tension pneumothorax or massive hemothorax as the primary cause of these findings, and an open pneumothorax would present with a sucking chest wound. For example, a stab wound so close to the heart often causes blood to collect in the sac around the heart, squeezing it and preventing it from pumping effectively. When you see Beck's triad, hypotension, muffled heart sounds, JVD, after a penetrating chest injury, think pericardial tamponade. Question 12. A 10-year-old child presents with a GCS of 13 after a bicycle versus car accident. He complains of headache and nausea. His pupils are equal and reactive. His vital signs are stable. What is the most appropriate initial diagnostic imaging study for his head injury? A. Plain skull radiographs. B. Non-contrast CT scan of the head. C. Magnetic resonance imaging, MRI, of the brain. D. CT angiography of the head and neck. Answer, B. Non-contrast CT scan of the head. This question focuses on the appropriate initial imaging for pediatric head trauma. The keywords 10-year-old child, bicycle versus car accident, GCS of 13, headache and nausea indicate a potentially significant head injury requiring evaluation for intracranial pathology. While GCS 13 is not severe, it's concerning enough post-trauma to warrant a CT scan. A non-contrast CT scan of the head is the rapid and most sensitive imaging modality to detect acute intracranial hemorrhage, skull fractures, or significant cerebral edema in the emergent setting. For example, if a child shows signs of concussion or mild traumatic brain injury after a car accident, a CT scan is essential to rule out dangerous bleeding inside the skull. Always use a non-contrast CT scan as the initial imaging of choice for suspected intracranial injury in pediatric trauma with concerning signs or mechanisms. Question 13. A patient presents with a severe crush injury to the right lower extremity. 6 hours post-injury, he develops increasing pain, paresthesias, and weakness in the affected limb, despite adequate analgesia. The calf is swollen and firm to palpation. What is the most appropriate next diagnostic and therapeutic step? A. Administer systemic antibiotics and elevate the limb. B. Obtain an urgent MRI of the lower extremity. C. Measure compartment pressures in the affected limb. D. Perform an emergency fasciotomy. Answer, C. Measure compartment pressures in the affected limb. This question tests the recognition and immediate management of compartment syndrome. The keywords severe crush injury, 6 hours post-injury, increasing pain, paresthesias, weakness, calf swollen and firm to palpation are classic signs and symptoms of acute compartment syndrome. While fasciotomy, D, is the definitive treatment, it should be guided by objective measurements of compartment pressures to confirm the diagnosis, especially if the diagnosis is not absolutely clear or to document the need. For instance, if a patient has a very firm, painful leg after an injury, measuring the pressure inside the muscle compartments can confirm if blood flow is dangerously restricted and guide the decision for surgery. Always measure compartment pressures when suspecting acute compartment syndrome to confirm the diagnosis and guide surgical intervention. Question 14. An 18-year-old male sustains a severe blunt chest injury resulting in 3 or more adjacent ribs fractured in 2 or more places, flail chest, on the right side. He is in significant respiratory distress with paradoxical chest wall movement. His SpO2 is 88% on 100% oxygen, and he is becoming fatigued. What is the most appropriate definitive management for his respiratory failure? A. Aggressive pain control with intercostal nerve blocks and non-invasive positive pressure ventilation. B. Endotracheal intubation and mechanical ventilation with positive end expiratory pressure, PEEP. C. Surgical fixation of the fractured ribs. D. Placement of a chest tube to re-expand the lung. Answer, B. Endotracheal intubation and mechanical ventilation with positive end expiratory pressure, PEEP. This question focuses on the management of severe flail chest leading to respiratory failure. The keywords severe blunt chest injury, flail chest, significant respiratory distress, paradoxical chest wall movement, SpO2 88% on 100% oxygen, and becoming fatigued indicate impending or actual respiratory failure. While pain control is important, intubation and mechanical ventilation with PEEP are necessary to stabilize the chest wall internally and provide adequate oxygenation and ventilation when non-invasive methods fail or are insufficient. For example, if a patient with a flail chest can't breathe well enough even with supplemental oxygen, putting them on a ventilator can help keep their lungs open and support their breathing until they heal. In cases of severe flail chest causing respiratory failure, early intubation and mechanical ventilation are crucial for support. Question 15. A patient with a GCS of 4 is found unresponsive at a construction site. Pupils are unequal. There is no obvious external trauma except for some abrasions. Blood pressure is 160/90 mmHg, heart rate is 60 bpm, and respiratory rate is 8. What is the most important initial treatment priority after securing the airway and assisting ventilation? A. Administer corticosteroids to reduce cerebral edema. B. Initiate therapeutic hypothermia. C. Administer an osmotic agent, e.g., mannitol or hypertonic saline. D. Obtain an urgent cervical spine CT scan. Answer, C. Administer an osmotic agent, e.g., mannitol or hypertonic saline. This question focuses on the immediate management of presumed increased intracranial pressure, ICP, in severe traumatic brain injury, TBI. The keywords GCS of 4, unresponsive, unequal pupils, and signs of Cushing's triad, high BP, low HR, low RR, strongly suggest severe TBI with elevated ICP and possible herniation. After securing the airway and ventilation, the most important initial medical treatment to rapidly reduce ICP and prevent further brain injury is the administration of an osmotic agent like mannitol or hypertonic saline. For instance, these medications work by pulling water out of the swollen brain tissue, thereby lowering the pressure inside the skull. In severe TBI with signs of elevated ICP, immediate administration of osmotic agents is critical to reduce brain swelling. Question 16. A patient presents to the trauma bay with an impaled object, knife, in the right upper quadrant of the abdomen. He is hemodynamically stable. What is the most appropriate initial action? A. Carefully remove the knife to assess the wound. B. Obtain an urgent CT scan of the abdomen with contrast. C. Stabilize the impaled object in place and prepare for surgical exploration. D. Perform a focused assessment with sonography for trauma, FAST, exam. Answer, C. Stabilize the impaled object in place and prepare for surgical exploration. This question addresses the critical principle of managing impaled objects in trauma. The keyword impaled object, knife, in the right upper quadrant is the central clue. The most crucial initial action is never to remove an impaled object in the field or the emergency department, as it may be tamponating a bleeding vessel or organ. Instead, the object should be stabilized in place to prevent further injury or dislodgement, and the patient should be taken directly to the operating room for controlled removal. For example, if a knife is holding a bleeding liver vessel shut, pulling it out could cause immediate, life-threatening hemorrhage. Always stabilize an impaled object and remove it only in the operating room. Question 17. A 68-year-old male with a history of coronary artery disease is involved in a head-on collision. He is hypotensive, 90/60 mmHg, tachycardic, 115 bpm, and complains of severe anterior chest pain. Breath sounds are equal, and his neck veins are flat. What is the most important initial consideration regarding his fluid resuscitation? A. Rapidly infuse 2 liters of warmed crystalloid solution. B. Administer crystalloid boluses cautiously, typically 250 to 500 milliliters, and reassess frequently. C. Prioritize blood product transfusion over crystalloid. D. Administer a vasopressor to improve blood pressure before fluid administration. Answer: B. Administer crystalloid boluses cautiously, typically 250 to 500 milliliters, and reassess frequently. This question highlights the nuanced approach to fluid resuscitation in elderly trauma patients, especially those with comorbidities. The keywords 68-year-old male, coronary artery disease, and hypotensive/tachycardic indicate a patient who is more susceptible to fluid overload but still requires resuscitation. While he needs fluid, a massive 2-liter bolus, A, might precipitate heart failure. Cautious, smaller boluses, e.g., 250 to 500 milliliters, followed by frequent reassessment are preferred to avoid fluid overload while addressing hypovolemia, especially if the source of hypotension is unclear. For example, an older patient with heart issues might not tolerate a large fluid bolus as well as a young, healthy patient, so smaller, repeated doses are safer. Always be cautious with fluid resuscitation in elderly patients with comorbidities, using smaller boluses and frequent reevaluation. Question 18. A 22-year-old male is brought in after falling from a scaffold. He is conscious but complaining of severe back pain. Neurological examination reveals lower extremity weakness and absent rectal tone. What is the most important initial step in managing his suspected spinal cord injury? A. Immediately administer high-dose methylprednisolone. B. Apply a rigid cervical collar and secure the patient to a backboard. C. Obtain an urgent MRI of the entire spine. D. Log roll the patient to assess his back for injury. Answer: B. Apply a rigid cervical collar and secure the patient to a backboard. This question tests the foundational principle of spinal immobilization in suspected spinal cord injury. The keywords fall from a scaffold, severe back pain, lower extremity weakness, and absent rectal tone strongly indicate a spinal cord injury. The most important initial step is immediate and meticulous spinal immobilization using a rigid cervical collar and securing the patient to a backboard or, preferably, a scoop stretcher and vacuum mattress, to prevent further injury during evaluation and transport. For instance, any movement of the spine before stabilization could worsen a spinal cord injury, so keeping the patient perfectly still is paramount. Always prioritize spinal immobilization immediately upon suspicion of spinal cord injury to prevent secondary damage. Question 19. A 30-year-old male presents with a large, actively bleeding scalp laceration after an assault. He is hypotensive, 90/60 mmHg, tachycardic, 110 bpm, and confused. His Glasgow Coma Scale, GCS, is 13. What is the most appropriate initial management for his scalp laceration contributing to his hypovolemia? A. Cleanse the wound and apply a sterile dressing. B. Apply direct pressure to the wound and then suture the laceration. C. Control bleeding with direct pressure, then assess for associated skull fracture. D. Rapidly administer intravenous fluids to restore blood pressure before addressing the wound. Answer: C. Control bleeding with direct pressure, then assess for associated skull fracture. This question emphasizes the immediate control of external hemorrhage in a trauma patient. The keywords large, actively bleeding scalp laceration, hypotensive, tachycardic, and confused highlight that the scalp laceration is a significant source of blood loss contributing to his shock, and that brain injury must also be considered. The most appropriate initial step is to immediately control the bleeding with direct pressure, as the scalp is very vascular and can cause significant blood loss, especially in shock. After controlling the bleeding, assessing for an underlying skull fracture is crucial before definitive wound closure. For example, a simple cut on the scalp can bleed a lot, so pressing on it firmly is the fastest way to stop the bleeding while you check for deeper injuries. Always prioritize immediate direct pressure to control actively bleeding scalp lacerations, and then assess for underlying bony injuries. Question 20. A 40-year-old female presents with a small, penetrating injury to the right chest, just lateral to the sternum at the fifth intercostal space. She is alert, has clear breath sounds, normal vital signs, and no JVD. A chest X-ray shows a small right hemothorax but no pneumothorax. A fast exam is negative. What is the most appropriate next step? A. Immediate chest tube insertion for the hemothorax. B. Observation and serial vital signs, potentially with repeat imaging. C. Urgent thoracotomy to explore the penetrating injury. D. Pericardiocentesis for potential occult tamponade. Answer: B. Observation and serial vital signs, potentially with repeat imaging. This question tests the management of minor penetrating chest trauma in a stable patient. The keywords small, penetrating injury, alert, clear breath sounds, normal vital signs, no JVD, small right hemothorax, and no pneumothorax indicate that the patient is currently hemodynamically stable with minimal injury. In such cases, if the hemothorax is small, e.g., less than 300 to 500 milliliters or covering less than a third of the hemothorax, and the patient is stable, observation with serial vital signs and repeat imaging, e.g., repeat chest X-ray or CT, is often appropriate. For instance, a small amount of blood in the chest might resolve on its own, so rushing to put in a chest tube might not be necessary if the patient is stable and showing no signs of distress. Avoid aggressive interventions in stable patients with minimal findings. Question 21. A 5-year-old child presents after being struck by a car. He is conscious, but drowsy, with abdominal tenderness. His blood pressure is 85/50 mmHg, heart rate 140 bpm, and capillary refill is 4 seconds. There are no obvious external signs of major hemorrhage. What is the most appropriate initial fluid resuscitation strategy? A. Rapid infusion of 20 milliliters per kilogram crystalloid bolus, repeated as needed. B. Slow infusion of 10 milliliters per kilogram crystalloid over 30 minutes, followed by re-evaluation. C. Immediate transfusion of O-negative packed red blood cells at 10 milliliters per kilogram. D. Administer a rapid bolus of 5 milliliters per kilogram hypertonic saline. Answer: A. Rapid infusion of 20 milliliters per kilogram crystalloid bolus, repeated as needed. This question assesses knowledge of pediatric fluid resuscitation in hypovolemic shock. The keywords 5-year-old child, struck by a car, drowsy, abdominal tenderness, hypotensive, tachycardic, and capillary refill 4 seconds clearly indicate hypovolemic shock. The standard initial fluid resuscitation for pediatric trauma patients in shock is a rapid bolus of 20 milliliters per kilogram of warmed isotonic crystalloid, like normal saline or lactated ringers, which can be repeated. For example, a child needs specific fluid amounts based on their weight, and a 20 milliliters per kilogram bolus is designed to quickly replace lost volume. Remember that pediatric patients can compensate for shock for longer, but decompensate rapidly, so prompt and appropriate fluid resuscitation is critical. Question 22. A patient with a presumed unstable pelvic fracture is undergoing resuscitation. Despite aggressive crystalloid and blood product administration, the patient remains hemodynamically unstable. A pelvic binder has been applied appropriately. Which of the following is the most appropriate next step to control hemorrhage from the pelvis? A. External fixation of the pelvic fracture. B. Angiographic embolization. C. Open surgical exploration, laparotomy. D. Application of resuscitative endovascular balloon occlusion of the aorta, REBOA. Answer, D. Application of resuscitative endovascular balloon occlusion of the aorta, REBOA. This question addresses the advanced management of refractory hemorrhagic shock from an unstable pelvic fracture, incorporating a 2025 ATLS update. The keywords unstable pelvic fracture, remains hemodynamically unstable despite aggressive crystalloid and blood product administration, and pelvic binder applied indicate persistent, life-threatening hemorrhage. After initial measures, REBOA is a critical tool to temporarily control bleeding from the pelvis or abdomen by occluding the aorta, buying time for definitive interventions like angiographic embolization, B, or surgery. For instance, if a patient is bleeding out from a pelvic fracture and nothing else is working, REBOA can temporarily stop the blood flow to the lower body, giving surgeons time to find and fix the bleeding. Consider REBOA as a bridge to definitive hemorrhage control in patients with uncontrolled truncal bleeding who remain unstable. Question 23. A patient with a severe closed head injury is being prepared for transfer to a higher-level trauma center. His GCS is 7, and he requires mechanical ventilation. Prior to transfer, what is the most critical aspect to ensure during initial stabilization and packaging? A. Placement of a feeding tube for nutritional support during transport. B. Ensuring normocapnia, PACO 235 to 45 mm of mercury, and cerebral perfusion pressure, CPP, optimization. C. Prophylactic administration of broad-spectrum antibiotics. D. Obtaining a comprehensive social work assessment. Answer, B. Ensuring normocapnia, PACO 235 to 45 mm of mercury, and cerebral perfusion pressure, CPP, optimization. This question emphasizes the critical elements of stabilization for transfer in severe traumatic brain injury, TBI. The keywords severe closed head injury, GCS7, and mechanical ventilation highlight the patient's severe brain injury and the need for careful management to prevent secondary brain insults during transfer. Maintaining normocapnia, not hyper or hypoventilating, and optimizing cerebral perfusion pressure, CPP, are paramount to prevent further ischemic damage to the brain. For example, maintaining the correct carbon dioxide level and blood pressure ensures enough blood flow to the injured brain, which is vital during transport. For severe TBI patients being transferred, always focus on maintaining normocapnia and optimizing CPP. Question 24. A patient with a large open pneumothorax, sucking chest 1D, on the right chest is brought to the trauma bay. He is in moderate respiratory distress. What is the most appropriate initial management for the open pneumothorax? A. Immediately place a chest tube. B. Intubate the patient and initiate mechanical ventilation. C. Apply a 3-sided occlusive dressing. D. surgically close the wound. Answer C. Apply a three-sided occlusive dressing. This question tests the immediate management of an open pneumothorax. The keywords large open pneumothorax, sucking chest wound, and moderate respiratory distress indicate a critical injury where air is entering the pleural space directly through the chest wall. The most appropriate initial management is to apply a three-sided occlusive dressing, e.g., petroleum gauze or plastic wrap taped on three sides. This acts as a one-way valve, allowing air to escape during expiration but preventing air from entering during inspiration, which prevents a tension pneumothorax. For example, putting a dressing on three sides creates a flap that lets trapped air out but doesn't let more air in. Always apply a three-sided occlusive dressing to an open pneumothorax to prevent tension pneumothorax. Question 25. A 40-year-old male is brought in after an explosion with full-thickness burns to his face, neck, and circumferential burns to both upper extremities. Initial assessment reveals stridor, hoarseness, and significant facial edema. What is the most immediate life-saving intervention indicated? A. Administer large-volume fluid resuscitation. B. Perform an escharotomy on the circumferential arm burns. C. Administer prophylactic antibiotics. D. Secure the airway with endotracheal intubation. Answer D. Secure the airway with endotracheal intubation. This question focuses on the immediate priority in burn trauma, specifically airway management in the presence of inhalation injury. The keywords explosion, full-thickness burns to face, neck, circumferential burns to both upper extremities, stridor, hoarseness, and significant facial edema are all strong indicators of impending airway obstruction due to inhalation injury and edema. Securing the airway with endotracheal intubation immediately is paramount, as edema can progress rapidly and make intubation impossible later. For example, if a patient has burns around the face and neck, swelling can quickly close off the airway, so putting in a breathing tube early is crucial before that happens. When signs of inhalation injury or impending airway obstruction are present in burn patients, secure the airway without delay.